Good morning or good afternoon, depending on when you're listening. This recording will serve as a SOAP note refresher to provide additional guidance for the third SOAP note revision due later this week. So it's just sort of a follow-up to the SOAP note lab from week 5. What we're going to do during this time is to look at the SOAP note template that you all have in your documenting pharmacy services packet that was used for the original SOAP note for this lab. And we're going to compare that to a sample SOAP note, sort of an ideal of what the SOAP note should look like when finished, so that you can use this for your revision due later this week. So we'll just start from the beginning and compare the template with a sample note. And we'll start with the subjective and the chief complaint. So for this particular case, we have a 55-year-old female who presents for follow-up on blood pressure and cholesterol. And you'll note that for the chief complaint, you should use the patient's own words for why they're coming into the pharmacy or the clinic that day. Then, next you have the HPI, or the history of present illness. And you'll note in the template that you can use the old charts mnemonic to sort of outline what the patient said in detail about their chief complaint. So the HPI sort of only addresses the complaint that the patient is coming in for, the one that you're focusing on for the visit. And it's going to be documented similarly to the way that you would interview the patient regarding that complaint, just like the old charts mnemonic, to go over alleviating or aggravating factors, onset of the complaint, duration, location if that's pertinent, etc. So for this patient, she states that her blood pressure has been good at home, but presents with a log of blood pressure readings ranging from 158 to 146 systolic over 74 to 88 diastolic. So you may not interpret that as being good, but that's what the patient is reporting. She takes her blood pressure at rest and has also decreased her sodium and caffeine intake, and she's taking her current blood pressure meds as directed and reports no side effects. She also tells you that she's been taking atorvastatin as directed without side effects and denies muscle pain and cramping. So that's your HPI. So it should be pretty brief because it's focused on one complaint or related complaints. And then you have your past medical history, which is a full list of everything that the patient has been diagnosed with and the date of the diagnosis if that's available. And a lot of times it won't be, but if it is, it should be documented because that can affect your assessment and plan. So anything that can affect your assessment and plan should be included in your subjective and objective information. So this patient has a history of stable angina, which was worked up and found to be atherosclerotic heart disease in May of 2016. She has esophageal reflux, hyperlipidemia, hypertension, moderate persistent asthma, depression, and tobacco use disorder. She's never had any surgeries, but it's still pertinent that she hasn't had any surgeries, so that should still be in the subjective information. Family history is listed because that's always going to be important to know. And then the social history. So this patient is a current smoker but denies alcohol and illicit drug use. The medications, if they are from the chart or the EMR or the pharmacy med list, they go in the objective section. So remember, anything provided by the patient goes into the subjective section, and then things that you find from the chart are more objective. But knowing that you are a pharmacist and interviewing a patient and writing it up in your SOAP note, you probably have asked the patient about medications, and you may have found out things about adherence, how they take the medications, when they take them, any discrepancies, any over-the-counter medications, herbals, that kind of thing. So any kind of conversation that you have about meds that may differ from what's listed in the chart can be mentioned in the subjective and should be mentioned in the subjective section. So here we've listed that the patient confirms adherence to all medications as listed in the chart and states occasional ibuprofen use, but no other OTC medications. So if a patient told you that they take their medication somehow differently than the meds are listed in the chart, or any OTCs or anything like that, that can be listed in the subjective section, and then the meds listed in the chart can be listed in the objective section, so that it's clear that there is a discrepancy, and then that would be then addressed in your assessment and plan. So again, just to simplify, anything regarding the medications the patient tells you can be briefly mentioned in the subjective, meds found in the chart listed in objective. And that's been something that I think is maybe a little bit less clear. Allergies are always important to list. This patient does not have any allergies, but it's still important. Even when things are negative, they can still be pertinent, so it's still pertinent to list that there aren't any allergies. Then you have the review of systems. Sometimes you'll see this as a paragraph, and sometimes you'll see it listed by system. I think in a lot of cases it is easier for the reader if it's listed by system. So that's what I've done here, but it is not necessarily wrong to have it in a paragraph form. And again, pertinent positives and negatives. So anything that the patient lists that is going on, any complaints that they do have as you go through the systems should be listed. But it's also important to note things that the patient is not experiencing, because that helps you in the assessment and plan to justify ruling out certain things. So, for example, for this patient, we know that she has a history of stable angina and atherosclerotic heart disease, but currently she's not complaining of any chest pain or palpitations, so we don't necessarily need to address that today. She also is denying cough, wheezing, shortness of breath, or excess albuterol use, so we don't necessarily need to address her moderate persistent asthma during this visit. So that's sort of a recap or another example of why it's important to include both pertinent positives and negatives. So this patient denies heartburn, abdominal pain, that kind of pertains to the GERD, and no chest pain or palpitations, which is good. A normal ENT and eye exam or report from the patient, and then everything else looks normal, but it's still important to include. And then that takes us to the objective information. It is again important here to put pertinent positives and negatives when you're talking about vitals, labs, and any sort of diagnostic testing. So for this patient, we always want to put vitals. So you can see here the patient's height and weight and BMI. So this patient is obese, which contributes to their cardiovascular risk. So that's pertinent to this patient for sure. The respiratory rate and heart rate and blood pressure are also listed. So you can see the blood pressure is a little bit elevated during this visit as well. The labs, it's also important to put the date of when the labs were drawn, because if labs are from 2 years ago, they're not necessarily accurate, up-to-date, pertinent, etc. So depending on the date of your lab, you may recommend additional labs in your assessment or plan, or you may have labs that are up to date that you can use to make assessments and plans. So this patient, we've listed the serum creatinine and the BUN, as well as the potassium. That all relates to renal function, obviously, and you've got a patient on lisinopril being the most important medication that we worry about from this med list in regards to renal function, potassium for the same reason. Glucose is listed because this patient has hypertension, hyperlipidemia, this patient smokes, this patient's obese, all cardiovascular risk, and all also reasons that we want to monitor the risk of the patient developing diabetes. So you see a normal glucose, which is a pertinent negative. You also have your total cholesterol, triglyceride, HDL, and LDL, because we have a patient with hyperlipidemia, so we're assessing that. And then A1C, again, cardiovascular risk. So then you see your medications listed there. Those are the medications from the chart. So that's why they're listed in the objective section. And then finally, diagnostic tests. So this patient had a coronary catheterization in May of 2016, which showed mild coronary atherosclerosis, but normal left ventricular function and no valvular disease. So this patient has evidence of atherosclerosis and also symptoms in the stable angina, which currently the patient is not experiencing. And so this patient it's been recommended that this patient just be treated medically without intervention at this time. But still, it's important to know that this patient does have evidence of atherosclerosis, and we'll see why as we go through the assessment plan. This patient also had in the chart pulmonary function tests reported. Now, we're not necessarily addressing the asthma today, but if we were, it would be important to include those pulmonary function tests, which sort of revealed more of an asthma picture rather than COPD. So that may affect the medications you use and that kind of thing. So it's not necessarily pertinent to this case, so it's not included. But if you were addressing something else, you may include that. So again, positive and negative pertinent information. Okay, so that takes us to the assessment. One thing that's very important for the assessment and plan is that it is listed, and it states it in your template here, that you are going to talk about what you think the patient's problem is based on the subjective and objective findings. That does not mean that you have to repeat those specific subjective and objective findings, and you shouldn't do that. In the interest of brevity, it's not appropriate to repeat or restate subjective or objective information in the assessment. So, for example, you wouldn't say the patient's blood pressure was 150/88, you would say the blood pressure is uncontrolled because the reader can see that it was 150/88. So your assessment would say something like blood pressure is uncontrolled at greater than a goal of 140/90 per JNC8. So you want to include your goal to sort of outline your assessment of if it's controlled or uncontrolled. So again, try not to include subjective information or objective information in your assessment. You're just going to assess rather than restate. The other thing is that all active problems should have an assessment, and you should include all the reasons for your assessment, and it should be problem-oriented and listed in numerical order as the diagnosis or differential diagnosis. And I think that as a pharmacist, sometimes we want to list medication-related problems rather than diagnosed problems like hypertension, hyperlipidemia, etc. So your problem list sometimes would look like ACE-induced cough as number one, inappropriate antidepressant as number two, a side effect to a drug as number three. Those should go under the diagnosis for which they're being used. So an ACE-induced cough would go under the category or diagnosis of hypertension. And that just helps organize your thoughts, and that helps you not repeat information. So you can see here we have prioritized the problem list, and it is listed by disease state or diagnosis. So first we have hyperlipidemia, then hypertension, then mild persistent asthma, depression, GERD. So sometimes you'll write a note that includes all of the different problems or diagnoses, and sometimes it'll be a more focused note. So for example, if you're doing, let's say that you find yourself on rotation in an anticoag clinic, you're going to write a note just based on anticoagulation, and you may not include all of the different disease states. And sometimes you'll be in a setting where it is appropriate to include every disease state in your assessment plan. So just for completeness, I've included all of the diagnoses that need to be addressed for this patient. And then for your plan, it should mimic the assessment. So you see here hyperlipidemia, hypertension, mild persistent asthma, depression, GERD. Same thing in your plan. Hyperlipidemia, hypertension, mild persistent asthma, depression, GERD. Okay, so that just helps organize everything. So your assessment and plan should sort of summarize the visit and the recommendations or interventions that were made. So for hyperlipidemia, again, note that we're not going to repeat information, but we are going to assess it. So we have a patient that was noted in the objective information to have atherosclerosis. So for hyperlipidemia or cardiovascular risk, our assessment is that the patient is a candidate for high-intensity statin to prevent cardiovascular events, giving findings consistent with atherosclerosis and tolerating moderate intensity statin well. Would benefit from continued aspirin therapy and an increased dose of atorvastatin with continued monitoring. So your sort of verbiage and the way that you put things in the assessment, you're going to use statements like candidate for, would benefit from, and you're going to be a little bit more vague because you want to justify what is coming in the plan. So this patient, because of the diagnosis of atherosclerosis, is a candidate for high-intensity statin for ACC/AHA guidelines. So in the assessment, we're not going to say increase atorvastatin to 40 or 80 milligrams, but in the assessment, you're going to assess that that needs to be done, and then your plan will outline the more specific plan, which says continue aspirin 81 milligrams once daily and increase atorvastatin to 40 milligrams once daily for additional primary prevention of CV events. And then your assessment is that you want to continue to monitor, and then your plan is what you would specifically do. So you would continue to monitor for signs and symptoms of myalgias with the increased statin dose, a fasting lipid panel in 8 weeks, and LFTs and CK as needed based on symptoms. So again, we're just monitoring for side effects and then efficacy or adherence with the fasting lipid panel and the increased statin dose. Your template does show that monitoring parameters and patient education are separate from your actual plan. In practice, it generally makes more sense to put your monitoring with the plan that you're monitoring. So you'll see the monitoring for this patient actually in with each specific disease state, as well as the patient education. So for hyperlipidemia, we just went through the monitoring, and we're going to educate the patient regarding the dose change, the risks and benefits of statin therapy, and then also a healthy diet and exercise regimen. You want to be somewhat concise when you're going through the education that you provide so that it's clear when you go back and read the note. If you're seeing the patient again, you know what you did the previous time. But again, we're also, in the interest of brevity, going to try to be concise because you want providers to reference your note and know what was done and read through that. And so you don't want to be excessively wordy because a lot of providers don't have time to read through a really extensive note. So it needs to be just enough information to get an idea of what happened during the visit. Okay. You also want to keep in mind in your assessment and plan your audience. So if you're writing a SOAP note in practice, the reader is probably going to be a healthcare professional, another pharmacist, or a physician, or something like that. And so you don't need to go into the mechanism of action of drugs or why you wouldn't do certain things, why you wouldn't implement certain medication changes instead of the one that you chose, like you might be more inclined to do in an academic setting in your classes where your reader is a faculty member who is assessing your knowledge. So you don't have to say, if you were assessing, let's say, atorvastatin, since we've been talking about atorvastatin, you don't need to go through the mechanism and what different level of intensity the statins are and why you wouldn't use 20 of atorvastatin or pravastatin or something like that. You would just need to do a brief statement of why you want to make the change, why the patient would benefit from the change, and then move on to the plan. And that keeps your assessment and plan a little bit more brief. So back up to the assessment in hypertension. The blood pressure is uncontrolled at greater than 140/90 per JNC8 guidelines on low-dose lisinopril with borderline low potassium and normal renal function. That one brief sentence tells you that the blood pressure is uncontrolled. It tells you the goal, tells you what the patient is on, and instead of saying lisinopril 10, you can say something like low-dose lisinopril because that would justify increasing the medication versus adding something else. It's just more explanatory in nature. And then with borderline low potassium and normal renal function, that's going to justify also increasing the lisinopril. Because you know your potassium's not too high, you know it's safe based on the renal function. So you can actually be very brief and get a lot of information in your assessment. And then the patient would benefit from increased lisinopril dose and continued monitoring, which will be outlined more in the plan. So we're increasing the lisinopril to 20 milligrams once daily in the plan. We're going to recheck a CMP, so your kidney, liver function, and electrolytes, in 2 weeks to assess potassium and kidney function. And if within normal limits, may continue to increase lisinopril based on blood pressure lowering needs to reach a goal of less than 140/90. So you can see we have the goal in the assessment and the plan. You can also see there's a goal in your plan for hyperlipidemia, which is to prevent CV events. So that should also be listed. Mild persistent asthma, well controlled on inhaled corticosteroid long-acting beta agonist combination as evidenced by infrequent rescue inhaler use. So this wording is okay, even though it sort of repeats subjective information. But what would be more wordy and maybe less appropriate is that if you said the patient reports that she doesn't use her inhaler very often, or she reports she uses it once or twice a month, or something like that. This is a brief statement of why the persistent asthma seems to be controlled, and so the patient would benefit from continued therapy. Your plan is exactly what you're continuing. So the Brio Ellipta once daily, and then educate patient regarding the importance of daily dosing of controller medications and rinsing out mouth after use to avoid thrush because there is a steroid in that inhaler, and then to avoid asthma triggers, and then continue to monitor for increased wheezing or shortness of breath and increased rescue inhaler use. So in that one sort of brief plan, you've addressed the plan, the education, and the monitoring. For depression, stable on moderate bupropion dose without depression symptoms would benefit from continued therapy. And then we're just going to continue the medication and continue to monitor for depressive symptoms. And then ideally you would have some education there. But for things that are controlled, that you're not really changing anything, you don't always need as much in your assessment plan. And then for GERD, no evidence of persistent GERD symptoms on omeprazole 40 milligrams once daily. Consider decreasing omeprazole to avoid potential complications of long-term PPI use. So we know that PPIs aren't meant to be chronic medications, and they can cause bone loss, osteoporosis, potentially C. diff, and then there's some data regarding Alzheimer's disease or cognitive decline, CKD, cardiovascular risk, etc. And so we don't want to continue PPIs long term. So if we can discontinue it, that's something that we need to consider. So here we can decrease the omeprazole to 20 milligrams once daily, may take ranitidine 75 milligrams, PRN heartburn symptoms, and will monitor for return of those symptoms, continue to try to taper off the PPI. Because remember, we do have to taper those medications to prevent sort of a rebound effect. So here you've got an organized list of all your problems in the assessment and the plan. They correspond to each other, and your assessment sort of, if you are the reader and you read the assessment, you should be able to guess the plan. And then the subjective and objective is the information that is used to develop the assessment plan. So you can get a lot of information in a pretty brief note if you remember to not repeat your subjective and objective, but your pertinent positives and negatives, rather than I think what is often sort of the initial reaction is to put in everything that's abnormal. For example, for labs, put in all your abnormal labs in the objective. Well, that doesn't necessarily pertain to the disease states that you're assessing in your note, and it may have been assessed in a previous note, or it may not need to be assessed. But if you do put your pertinent positives and negatives, then you'll be able to justify continuing things if everything is normal, or changing things if you have abnormal results. So anything that's pertinent to what you're assessing should be listed. And you'll note that in practice, some providers will have some minor stylistic differences or preferences, but the template that you've been given is a very basic template that should guide you in writing a good, appropriate SOAP note. So hopefully this will help as you revise your SOAP note from your hypertension case that's due on Friday. Please feel free to email me, trotterj at etsu.edu if you have any questions, and good luck. Thanks.